Everyone in the Americas, good afternoon to everyone in Europe and Africa, and good evening to everyone in Asia and Australasia. My name is Steve Lacey. I'm the Director of Education for the ISRRT, and welcome to everyone to this August edition of the ISRRT monthly webinar series. It's great to have you all on here. And we have again with this one teamed up with the Canadian Association of Medical Radiation Technologists, and who are proud to support the ISRRT in this webinar presentation of what we call Precepting 101, Developing Adaptive Expertise. So learning from trial and error is foundational to competency development during the clinical placement. And being able to learn and grow from error requires adaptive learning skills. And in this presentation, you're going to hear the quality debriefing skills that foster adaptive learning and skills and create psychologically safe learning environments. The presentation will discuss adaptive learning in the Canadian clinical context, and you'll learn approaches that can develop adaptive expertise, identify approaches that might adapt well into other learning settings, and develop successful debriefing strategies for educators in clinical education settings. And as always, if you do have any questions today that you would like to ask our presenter, then please put them into the chat and we'll go through them at the end of the presentations. And also pop into the chat as well where you're from and how excited you are to be part of this webinar today. So let's introduce our presenter. So this is Dr. Marcia Doherty. Dr. Doherty was the lead practice learning and simulation at Ireland Health and is now the associate faculty in the School of Leadership Studies at Royal Roads University. She's also a member of the Canadian Association of Medical Radiation Technologists, and it's really exciting to have Marcia here on today to give us this presentation on Precepting 101. Thank you, Marcia, and take it away.
Hi, I'd like to welcome everyone to this webinar entitled Precepting 101, Developing Adaptive Expertise. I'm excited to be presenting on this topic today because learning from trial and error is foundational to competency development during a clinical placement. But being able to continually learn and innovate from error requires adaptive learning skills. In this presentation, we'll explore how to support adaptive expertise development as a preceptor. But first, a little bit about me. Before I introduce myself, I'd like to get us started in a good way. I invite you to plant your feet gently on the lands you find yourself today and create a space for the next hour to learn and connect. I'm placing my feet today on the territory of the Coast Salish peoples in Victoria, British Columbia, Canada, which was known for centuries for its camas meadows, shown in this picture that I took. Camas was a main starch food and export item, and these meadows are now being restored in the Lekwungen territories. I am Marcia Doherty, and I'm a practitioner scholar and began my career as a nuclear medicine technologist. I evolved my career into post-secondary or education, where I taught nuclear medicine technology and then moved into the academic administration of undergraduate and continuing professional development programs across allied health, nursing, and medicine. In all my roles, I have a passion for supporting quality work integrated learning experiences or clinical placements. Most recently, I've been supporting student placements, the transitions of new graduates and internationally educated professionals, and supporting their clinical educators, mentors, and managers to do the same. And I've opened a student-run sonography clinic. As well, I have been teaching emerging healthcare leaders to lead engaged, action-oriented change at Royal Roads University. In my scholarship role, I have brought an evidence-informed approach to clinical placements. I've been presenting at national and international conferences on clinical learning and preceptorship since 2006, and I'm sharing here some of the peer-reviewed research I've published. And I just want to say I have nothing to disclose. So in this presentation, we're going to examine the importance of adaptive expertise in MRT education, analyze why adaptive expertise is required to develop clinical capability, utilize debriefs to develop the learner's adaptive expertise, and develop and measure adaptive learning skills in clinical settings. So in this presentation, I have it organized where we're going to look at first at a definition of adaptive expertise. We're going to look at the learning theories that inform it, how to develop it. We'll look at a debriefing technique, and then talk about how it could be measured and whether or not we should be adapting the preceptor model. So what is adaptive expertise? It's easy to identify when it's absent, and a good example that we might have all experienced is calling a customer service line. Have you ever had a problem that you needed resolved and had difficulty getting this customer service agent to understand your problem? Have you ever given up in frustration because you felt they just weren't listening to you? I certainly have, and as an example, I've been having recent issues with a digital TV box for my television services. The box stopped working, and so they sent me another one, which stopped working shortly after I got it, and so they sent me another one, and it again stopped working. So even though they sent me 3 boxes, every time I call the agent, they still walk me through their entire script to make sure it's the box that's not working or it's something that I've done. This is not an example of adaptive expertise. Adaptive expertise is harder to identify when it's present because everything is working well. We can call it excellent customer service. And I chose this slide with this particular image because we're also experiencing artificial intelligence informing some of our customer service. And artificial intelligence is using the same learning approach that is utilized in adaptive learning. Machine learning is based in situated cognition, which is about learning in context. So what is adaptive expertise? In our MRT workspaces, adaptive expertise is about problem solving that unusual or tough case. It's about personalizing the patient's examination to maximize their comfort and understanding. It's successfully navigating the healthcare system to get that urgent care for your patient based on the results you're seeing in the exam. It's fitting in that stat patient and still leaving on time. It's completing your work on schedule while precepting a student. It's conducting a project over and above your assigned work. And it's developing a schedule that increases the number of patients seen each day. Adaptive expertise is recognizing when your familiar skills and knowledge are insufficient for novel, complex, or uncertain situations, and then adapting your familiar skills accordingly by innovating or refining your approach. In other words, it's about figuring out how to make our work lives better for ourselves and others instead of staying with the status quo. Adaptive expertise was first conceptualized by Hatano and Inagaki in 1986. It involves being both efficient and innovative, and it requires breaking free of old routines and discovering new ideas. 2 of the learning theories that are commonly cited to support adaptive expertise are Schwartz's preparation for future learning and Schoen's reflective practice. It requires attending to contextual cues and transferring prior knowledge to adapt practices. And I like to talk about it, it's about seeing self in system. Adaptive expertise is different than routine expertise. Routine expertise is focused on developing efficiency and being competent. It comes with this idea that knowledge is static and you need to master common problems. It's about learning how to follow protocols and remembering solutions. There's a functional fixedness about routine expertise, but it will lead to expertise. And it really focuses on the cognitive and psychomotor domains of acquisition of knowledge and skills. Now, adaptive experts not only gain routine knowledge, but they also organize and reorganize that knowledge so that they can innovate It means that they have capability. They recognize that knowledge is always changing and is dynamic. They're able to transfer their routine skills to unfamiliar situations. And they attend to the somatics, or the signals that you get from your body and your emotions, to cue you that there's something wrong. It helps them to identify and solve problems, and they demonstrate adaptability as well as reflexivity, or double loop learning, as Schoen calls it. It also includes the affective domain when you're looking at preparing for future learning. So some argue that adaptive expertise develops from routine expertise and can be developed once an initial level of efficiency has been achieved, while others argue it should be developed in parallel as it involves different skill sets. But all agree that developing efficiency and innovation together are the ideal goals for creating adaptive expertise. In medicine, Kutter et al. Suggests thinking about it as an optimal adaptability corridor. You want to increase efficiency and innovation in parallel. So what is the learning that's happening to develop adaptive expertise? It is about learning in systems. No learning is what was happening every time I had to call the customer service agent about my digital TV box. Simple learning is what we're probably most familiar with. It will result in developing the routine expertise expected in our professions, the positioning skills, the IV skills, the documentation skills. And generative learning will develop adaptive expertise for solving novel or ill-structured problems, navigating uncertainty, and experimentation. So let's look at each one in a little more detail and the role of the preceptor in each. I want to start with simple learning, as this is probably what everyone is most familiar with in the clinical placements. This is how we learn to assess our IV insertion and change our approach in similar cases. It's how we review our images to see if we could improve the positioning. It adjusts the way we page or communicate with the radiologist or manager based on their response. So we conduct our actions, and then we look at the results, and based on the results, we change our actions. Some of our students come with the ability to evaluate the results and improve their actions based on what they see, and some don't. And this is the foundational learning approach of the preceptor model, because it supports skill and routine development. And this is your role as the preceptor, to evaluate the results from the position of the expert and debrief the results to improve the student's skills and abilities. However, this approach doesn't typically change the frames or the mental models of the student, at least not in a significant way. Our frames are our mental models and our schema that inform our choice of actions, and they inform the range of actions that we can choose from. These frames are like filters that we apply in our diagnostic and therapeutic images. Depending on the filter applied, different aspects of the image become more or less apparent because information gets filtered in or filtered out. For most of us, we're largely unaware of our filters and our frames. Generative learning, on the other hand, does change our frames. It's the type of learning that will develop adaptive expertise. Generative learning uses the results of actions to reflect the frames that generated the actions and possibly change the frames and then the actions and then the possible results. This in turn helps you to identify new strategies and new classes of actions that weren't possible before with the old frame. When you change a frame, it's often signaled by, oh, I hadn't thought about that before. Oh, I had an aha moment. That's when you know your frames have been changed. In this situation, your role as a preceptor is to bring different frames in to expand the student's thinking that will change their actions in future and improve the results that they are able to produce. Debriefing that leads to adaptive expertise involves leveraging the results to develop new frames, new mental models, or new schemas, and more options for actions. Some refer to this as metacognition, or awareness of one's own thought processes. So some examples of this would be who and how to reach out for assistance. Students often come with the frame that they have to work independently and can't ask for help. How to include the patient in a meaningful way. For example, do your protocols take into consideration your organization's parking challenges? How to make decisions in high pressure situations. Students don't know that they have options to respond to a colleague who dismisses their request for help. Identifying who the customer you're serving at the moment. Are you serving the patient, or are you serving the physician, or are you serving yourself, or are you serving the organization with your approach? And lastly, let's look at no learning, where the frames and actions are not informed by the results. This is what happened to me when I called my television service provider and had to start from the beginning each time I called. In this case, actions are taken and there's no reflection on the results, and therefore there's no improvement or change on one's actions. So this is what automation looks like. This is what sticking with your habits or scripts or algorithms. And some examples in MRT are, when your images aren't quite correct because you assumed the patient could lie flat and you didn't check. It's when you reach for a supply and find out that you've run out of that supply because someone took the last one and it didn't get replaced. It's also that technologist you work with who's always running behind. And unfortunately, this can be the result when students go unsupervised in their placement and don't develop the skill for simple or generative learning. So as we saw earlier, the literature argues that efficiency and innovation should be developed in tandem in what they refer to as an optimal adaptability corridor. This means considering what your debriefing skills are supporting. Are they supporting simple learning and skill development based on feedback from the results? Or are they supporting generative learning and preparation for future learning that changes the choice of actions based on changing the frames or mental models? What research is showing is that early innovation yields better adaptability in the short term and efficiency in the long term. So that means if efficiency will come if you support generative learning. So debriefing to develop new frames, when done well, can remove the need to debrief change actions, as it moves the experience from the idea that knowledge is fixed and there is one right answer. Two, knowledge is dynamic and the preceptor may not have all the answers. This approach prepares the student to be continuously learning. Before we move on to debriefing techniques, let's look at the conditions needed to develop adaptive expertise. I've summarized 4 key points from the literature: clarify distinctions of what is routine and not routine, create opportunities for productive struggle, shift from doing things right to doing the right thing, encourage the development of a self-regulated learner, and I've added the importance of creating psychological safety. You need to be clear as to when and where students can be adaptive and where they can't. Where and when innovation is warranted. For example, scopes of practice and organizational protocols may need to be adhered to, whereas some protocols may be able to be adapted based on patient need or when the team is running behind schedule. The degree of adaptability expected from adaptive expertise is, where is flexibility afforded in the department? Is it just your individual imaging treatment work, or can staff contribute to improving the department work processes, or can they change the work processes in the organization as a whole? This brings me to individual versus systems gaps, because we often try and fix systems gaps by focusing on individuals. A common one I hear frequently is, if we just understood each other's roles and responsibilities, we'd be able to collaborate better. It suggests that there are knowledge gaps in individuals when it's probably the structures, practices, processes, and culture that's creating these gaps. The second point we need to do is create opportunities for productive struggle. Productive struggle involves hypothesis generation and problem solving when confronted with ill-defined problems with uncertain and multiple solutions. We do it by creating positive activation, which are challenging tasks outside the student's comfort zone. At the simplest level, let the student try to position that challenging patient. And at a more complex level, let the student try and develop an imaging or treatment plan for an unusual or rare case. Allow them to struggle and sometimes fail. Give the student the expected time frame to complete the work and don't extend the time. Instead, debrief their strategies and encourage them to try different strategies next time to stay on time. And then support with guided discovery. When you support with guided discovery, you're ensuring the student remains positively activated. If you provide too much direction, they can lose interest. And if you don't provide enough direction, they become too stressed, which then they won't be able to problem solve. So techniques you can use include coaching techniques, giving hints, testing their frames with why and what if questions, modeling your frames by making your thinking explicit. And rethink feedback to feed forward. Remember, you're preparing them for future learning. Model this by gathering feed forward from the student on how you're doing and what you might be able to do better. Finding the balance of how to support students with guided discovery does take time and effort to learn. The key here is don't let them struggle too long before providing support and guidance. And don't take over, but give support in microdoses. As preceptors, we need to find the balance between being totally in control or the opposite, abdicating control, letting the student figure it out on their own. There is a middle ground of supervision here, and that is what the students are hoping for in these learning experiences. So the third piece is to shift from doing things right, an outcome-based frame, to doing the right thing, a process-based frame. Move from the concept of producing experts and instead towards preparing future experts. Focus on the implications of variations versus presenting a repository of cases. Shift from not only adhering to the protocol, but also challenge the student to identify when they don't need to use the protocol, how they can adapt the protocol, what they might do if there isn't a protocol. Share the thinking behind the protocol. How could it change if the equipment changed, the physician was different, the patient demographics were different, you didn't have the same staffing model? Get them comfortable with not just following the steps, but collecting feedback in the moment to adjust their actions. And if you're sharing cases, don't just focus on an organ or system and the various pathologies. Also talk about how these pathologies would change the protocol and why. Bring cases that reflect the variety of cases you might see in a typical workday and discuss how best to organize them and mitigate any issues that might arise. Develop in them the habit of seeking feedback and feed forward. If we embrace the idea that knowledge is dynamic, then feedback and feed forward is something we need to be comfortable seeking and giving. And finally, integrate clinical knowledge with the patient, the organizational, and the societal context and values. How does your clinical work intersect with patient care, collaborative care planning, organizational goals and values, and larger societal expectations? Ask the question, who do your protocols serve? And fourth, encourage the development of a self-regulated learner. Some of you might be feeling a little uncomfortable right now with some of the ideas that I'm sharing because there's comfort in thinking that there's one right answer. We don't like messy problems that may have no right course of action. Neither do our students. And they're at a higher risk situation because they're being tested in a way that requires them to identify the right or best answer. So students do need to be able to self-regulate because self-regulation is a foundational requirement for being able to learn and to prepare them for future learning. They need to be comfortable with navigating the unknown. You need to debrief not only the cognitive and psychomotor domains of thinking and doing, but also the affective domain of somatic experience. In this case, debrief any emotion that arises in the mind or body in the moment when there isn't a right answer to be found. You want to encourage self-reflection on their emotions before their emotions take over and move the student into a stress response where no learning can occur. Model your own stress management approaches. For example, I'm noticing that you seem frustrated. I see that you're rolling your eyes. Your face is turning red. Can you share with me how you're feeling right now? I know when I'm trying to figure this out, I can feel my chest getting tight. And that signals to me it's time to take a little break, and take a couple of deep breaths. You can also debrief any emotion as feed forward, although this is often a bit harder because we can often forget how we were feeling in the moment. So you can ask, what was your experience during this process? Is there anything you can do to manage that experience better next time? The key here is that your emotions and somatic experiences are often contextual cues that your frames need to be changed. Encourage self-reflection. Have them asking, how am I doing? How am I doing as part of the team? Am I contributing equally? And finally, stimulate the willingness to learn, because to be continually learning versus arriving at a destination of competence shows that knowledge is dynamic. And then finally, a necessary component of precepting to develop adaptive expertise is creating psychological safety. Clark has identified 4 criteria. Inclusion safety. So is your student welcome? Learner safety. Do you encourage learning and growth? Contributor safety. Can you grant autonomy? And challenger safety. Are you prepared to be wrong? You need to be able to answer yes to these questions, as well as to be able to debrief effectively and with good judgment in order to create the psychological safety necessary to develop adaptive expertise. So learning in a system involves responding to results. In most cases, we don't notice when things are going right, but we sure notice when things are going wrong. In most cases, it's error that signals opportunities for learning. Error provides a learning opportunity that can improve actions and results when debriefed with good judgment. Debriefing with good judgment expands frames of reference. And I'm sure many of you may be already doing this. And I recommend using the advocacy inquiry approach developed in simulation because it illuminates the frames of reference. It encourages reflection that leads to the development of new frames. It can be used when things are going right, and it creates psychological safety. So instead of noticing error and going right into teaching mode and telling the students how to fix it, instead start with these types of phrases. I noticed that. What if? I noticed that you explained the procedure very comprehensively to that patient. What if they didn't speak English? I'm hearing that. What were you considering? I'm hearing that you're frustrated with your patient arriving late. How do you plan to mitigate their lateness to keep on schedule? I saw you. How are you feeling about this decision? I saw you acknowledging that the team was experiencing some challenges with a pediatric patient in the next room, and you didn't offer to help out. How are you feeling about that decision? Another feature of developing adaptive expertise is getting multiple perspectives, which counters the idea of absolute knowledge, and it facilitates the sharing of different perspectives or frames. So debriefing in group sessions can be very impactful, but I do want to caution you that it does require some skill and expertise. You can bring students together, colleagues together, and you can actually even include your patients in debriefing with the student. So here's some examples of some debriefing phrases to start with. What if? What if the equipment was down? Have you considered? Who else might you want to ask? When I'm making this type of decision, I might go for a walk. How might you change this if the patient was blind? These situations can make me feel very frustrated. What surprised you during this exam? How well did you do? What will you try next time? Debriefing provides an experienced perspective versus the idea that you hold absolute knowledge. You are not coming in with the right or correct way of doing things. You want to prepare them for future learning. It's tended to be interactive, bi-directional, and reflective. The goal is to create a master adaptive learner. So Cottrell et al. Identified that adaptive expertise requires an openness to reflecting on practice. It requires meta-reasoning skills to recognize that routine expertise schema stored in long-term memory will not work. It requires critical thinking to challenge current assumptions and beliefs, and it requires the ability to reconstruct the problem space. And they proposed that master adaptive learners follow an integrated process of planning, learning, assessing, and adjusting phases. So when measuring adaptive expertise, focus on the long-term goals versus short-term performance goals. Adaptive expertise is developed over time, so if you're setting goals for the placement with students, ensure they're not just focused on short-term performance goals. I need to complete so many procedures of this type. And include focus on more long-term outcomes, like managing uncertainty, changing a frame or mental model, feedback or feed-forward seeking, developing reflective practices, ability to adapt to new situations. Try and assess frequently and formatively. Give feedback and feed forward often and in the moment. Look for the skills of a master adaptive learner that are listed here. Move from pass-fail assessments to grading. Now, this is a recommendation for educational institutes. Consider moving away from pass-fail assessments and consider building rubrics that will allow for grading. And I'm happy to chat offline about this approach and if the educational institute you are providing placements for wants to move to grading of the practicum, embrace it. And then from Cottrell et al., they identified these are the skills that can be assessed in a master adaptive learner. In the planning phase, you should see examples of questioning, of prioritizing, of goal setting, of searching. In the learning phase, you should see them critically appraising the results and they applying appropriate learning strategies. In the assessing stage, they should be using an informed approach to their self-assessment and seeking external feedback. And then in the adjusting phase, they need to decide whether this new learning applies to routine or novel cases, and they need to consider whether this is a system or an individual implementation. Finally, as leaders in MRT practice and education, consider reframing or moving away from the common preceptor frames and mental models that you see themed here. We often talk about that we don't have enough equipment to support students. Our spaces are too crowded to support students. Our supervision quality is not always the best. It's difficult to balance clinical duties with learning opportunities. There's too many time constraints to effectively precept. We're not getting paid enough to take on this additional work. And there isn't sufficient collaboration with our educational partners. These barriers and issues were identified way back when I was a preceptor, and they're still here today. But there are enhanced simulation opportunities for the educational preparation of our students prior to their clinical placements. And here are some examples of that innovation. Virtual reality, gamification, haptics technology, and artificial intelligence can change the ways in which our students are prepared. And we should expect to see these advances and innovations lead to changes in the preceptor model. So we should collectively be supportive of these advances and advocate for them. There already has been some very interesting research on how the preceptor model can be adapted, and I encourage clinical leaders and preceptors to also consider contributing to evidence-informed innovation of the preceptor model if you haven't already. Manson et al. Has identified the importance of early clinical exposure with MRT students, which advance their academic performance, their clinical performance, and confidence. We often don't want these green students in our sites, but this is the ideal time to be developing adaptive expertise. I'm sharing some of my research where I co-developed a protocol for incorporating ultrasound students into the workload without having to increase the examination times for patients. Fourth-year nursing students have the option of being placed in collaborative learning units where they're not assigned to a preceptor. Instead, they work under a faculty member and lead their learning by selecting the patients on the unit that they want to follow during their placement. And finally, I'm seeing more student-run clinics where students are precepted as a group. These clinics can provide value as added services. For example, physiotherapy students running a fall clinic, student-run sonography clinics, or students providing services to remote, rural, and underserved communities. Ideally, this research should be conducted collaboratively between the Educational Institute and the work sites. In summary, precepting students to develop adaptive expertise requires attending to both efficiency and innovation. Focus not just on precepting for skill development, but also for future learning. Use debriefing techniques that help the student challenge their assumptions and reconstruct the problem space, and model adaptive expertise yourself. In closing, I'd like to thank you for attending this presentation, and I'd like to leave you with this quote from Richard Ragamise, one of Canada's foremost First Nations authors and storytellers. "Nothing in the universe ever grew from the outside in." I hope this presentation has expanded your mental models so that you can grow new approaches to your practice as a preceptor. If you want to connect with me, you can find me on LinkedIn or connect at marcia.docherty@me.com. Thank you.
Thank you, Marcia, for that wonderful presentation. I actually really liked that talk about the adaptive expertise, and I think there were some really good tips in there. What I really liked was the points about psychological safety, because I think that's often the difference between what might make a good clinical placement and what might make a poor clinical placement for some students as well. And I think that's also about the interaction with the individual supervisors themselves. And it's kind of, the way I see it as well, it's a very reflective practice too. So it forces the student to really reflect on their practice and think about looking at different situations that they might be able to apply those to as well. So, and that kind of comes into that critical thinking. Just a reminder to everyone that if you have any questions, please pop them in the chat. I've seen a couple of questions come up already, so thank you very much to those who have put some questions in. The one other thing, Marcia, I really liked was right at the beginning. You talked about how routine is demonstrating competence, whereas adaptive expertise is actually looking at capability. And I've always been a big advocate that there's a huge difference between what's competent and what's capable. Whereas a lot of people actually think that someone who's competent is also capable, but they're not the same thing. And I think that's probably the big thing to talk about. I don't know if you want to elaborate on that at all.
Yeah, thanks for bringing that up, Steve. It is a big difference, and I would suggest that most of our learners may not come with that ability to be capable, but we do. When I was doing the pair scanning research with the sonography students, what I ended up finding in the data was that in a class of 16 students, we may have one or two students who are probably able to do this independently without any instruction and without any guidance, and that they bring with it. And there was a paper on adaptive expertise in computer-aided design, and they found a significant difference in the ability of students to be adaptive, whether they were first-generation university students or not. So to me, that tells me that, in their home, because their parents were university students, they were probably prepared for university at a higher level than a first generation student. So they came with this skill set. And so what I found in this sonography data that there was only one or two of our students who actually come with that skill set. Because we like to throw our students in the deep end often. And in the data, I found one or two students would continue to excel in that situation, but the rest of the class would, after about 1 or 2 weeks, their performance would drop quite significantly. And then what I found was the average student took about 6 more weeks to get back up to where they started to. And then the 1 or 2 really weak students never recovered from that being thrown into the deep end.
Yeah.
So,
Okay.
so we do need to teach these our students how to be capable. They don't come with this skill set.
Yeah, yeah, absolutely. I think it's a very interesting point. I never really thought that those that were actually brought up in those homes that had experience or had parents that had experienced that university life, I guess, actually perform better. So it's interesting. I mean, it makes sense, but it's very interesting at the same time as
Yeah.
well. You did talk a lot about, or a little bit about trial and error when it comes to precepting. So one of the things I think I read in one of the slides said, allow them to struggle and sometimes to fail. And I think when dealing with patients, of course, like real patients, we as registered practitioners do have, I guess, the obligation to ensure the safety of our patients as well. So how do we as preceptors then ensure that people can still learn from those errors or sometimes fail, but still maintain the safety of the patient?
Right. So that's where we have to figure out where we can allow them to fail. So we can allow them to fail in the how long that they can take for the exam. So we often will indulge students and say, if it takes me 20 minutes to do this exam, it's okay if you do it in 30 or 40 minutes. What we would do is say, no, you need to do it in 20 minutes, just like I do it. And if they don't reach that 20 minutes, you take over and then you debrief that situation and say, okay, what do you need to do to get it to 20 minutes? You don't give them that sort of grace that you would for a student.
Yeah,
If if they're not starting the exam in a reasonable time, or maybe with the patient explanation or gathering the patient history. So maybe not in the actual imaging, because you don't want them retaking images or
yeah,
applying radiation inappropriately, but things like that, or give them something that it tests their skill set that they can do, but that's not involving the patient. It could be looking at the schedule and saying, how could you redesign that? As I said in the example for radiation therapy, it could be mapping out the treatment plan without any help,
yeah. I think
right?
it could also probably be in a way of if I'm talking like, I come from a clinical education background myself, and it could be just having to intervene when a student is working with a patient at some stage, knowing that there's about to be a mistake happening or something,
Yeah.
and then using that discussion afterwards in that reflective piece to say, okay, so you may have noticed that I intervened at a certain point. Why do you think that I intervened, and what do you think that was about?
Yeah, and how next time, how can it happen so that I don't have to intervene? What will you do next time? So
Exactly.
you really
Yeah.
put the emphasis on them, right?
Yeah, absolutely. We've got a question that's come through from Tyler from Winnipeg, who has asked to whether you can elaborate on the concept of the feed forward concept in this context.
Yeah, and thanks for that, Tyler. And it's feed forward is something that's it's a hard practice to learn, because what we're used to doing is critiquing error. So you can look at a patient and see that they're not centered in the image, and you can go, that patient isn't centered. And so instead of looking backwards and critiquing, what you want to do is stop yourself and then provide feed forward, which is guide their future action. So they've already messed up this image. The patient isn't centered and there's nothing they can do to fix it. So what you want to do is say, you know, So this, how might you help how might you in future center the patients more centered? How might you improve the positioning in this image instead of saying, oh, you did this, 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 and this wrong? Ask them how they might improve it next time. And it is a
So it's
tough
just about
technique.
reframing then, isn't it? Reframing the way, it's reframing the feedback to create that feed forward approach.
Yeah, and it is a tough skill to learn. It takes a while to learn it, and I kind of what I do is to remind myself, am I critiquing or am I helping them figure it out for next time? And you kind of have to let go. Yeah, you have to let go of wanting them to do it the right way or the right way that you think it should be done. Because that's often what the trigger is I would never have done it that way. And so I want to make sure you don't do it that way. So you have to let go of that sort of control piece of it too.
So I've always been a big advocate that positive feedback is just as important as constructive feedback.
Mhm.
Can the feed forward model be adapted to include that positive feedback as well?
Of course. I mean, that's what being adaptive is. You're demonstrating adaptive expertise. There will be situations where you do have to just debrief the results. But instead of coming in and saying, this patient isn't centered correctly, what I would suggest is coming in with the debriefing technique of, I can see that this patient isn't quite centered correctly. Do you agree? Or what happened? Why is that? And you might find out that you might find out that they thought they had centered it correctly and didn't know how to check. You might find out that the patient moved before they took the image and they didn't realize it. There may be other reasons why that happened than what you're thinking.
Yeah, absolutely. And another question's come through from Amanda Johnston, who has said, thank you, Marcia, that she really enjoyed expanding the frame on precepting students. For those of us who work in imaging practice who would like to try and implement or encourage more adaptive expertise in their current imaging staff, what would you recommend?
Oh, that's a very good question. And it really is about looking at what are the frames and talking to your team and trying to figure out what the frames are that they have uh, and start working on those frames and adjusting them. So you might find that they have frames that they have to adhere to the protocol. They may have frames that they're that the precepting is a burden. They may have frames that they can't make changes in the system. So it's really about having dialogues with them, creating a safe space for them to reveal what some of their frames are, so that then you can start addressing them. I've been doing a lot of work with new graduate nurses, and one of the big frames that they come with is that they can't challenge their colleagues or the physicians. And so we actually have to give them the language to challenge them. And we have to give them permission to ask for help. Like, you can ask for help. You're not alone. You can call a huddle. So it's quite interesting when you start creating this space to find out what kind of frames people have. Um, they may have the frames that your protocols don't make any sense. And if that's true, then you do need to look at your protocols.
Yeah, absolutely. I think it's also, I think a lot of this as well, and kind of what I'm getting from this is that within that student context, it's also about empowering students to be able to ask questions of people within that clinical context, because coming into a new clinical placement can be actually quite daunting for a lot of students because they don't know the environment, they don't understand. There's some people there that, may say we don't like students and things like that. So it's about then empowering them to speak up and say, I need some help with this, and how are you going to be able to help me with this at the same time?
Well, and also in the post-secondary, in their education, they're often they're being tested and told they need to be personally competent, right?
Yeah.
And so they see it as something that's residing in them, and that to ask for help might be a weakness and might be a demonstration that they're not competent, right?
Yeah, absolutely.
But the other thing too is really with your staff is to make it really just safe for them to bring their ideas forward and then shift them through dialogue. That seems to be the best approach. It takes a bit of time and it takes a lot of patience,
Yeah.
but the rewards are quite powerful.
They can be quite powerful, but I think that also sometimes people, particularly in very busy work environments, may think that there's not enough time to be able to do that with a student, as well as try to get get through the workload. And so that then kind of builds up and they end up going back and forth to go back into old habits as well.
Yeah, and then as a leader, going back to Amanda's question, model what adaptive expertise can and can't be in your department. Um, uh, and bring those to staff meetings, these ideas.
Yeah.
And like I say, when assessing, competence is assessed on the short term, but adaptive expertise is assessed on the long term.
And another question's come through from Jennifer Brown, who's asked, she really likes the thinking about overall outcomes rather than individual competency. What are your thoughts on students needing to develop competency before they can develop capability?
So you do need to come with some basic skills. I mean, you can't come into a clinical environment without some basic skills and competence in certain skills. I think what we this is kind of an interesting question. What we tend to do is we tend to put too much emphasis on this competent skills and not enough emphasis on the innovative adaptive skills. So, for example, if I use the green student, sometimes there's post-secondary educational institutes that like to put their students before they've even had any theory or labs or anything, they come in and do observational placements, right? And we don't think we can actually put them to work, but they come with skill sets and they come with competencies. They come with competencies perhaps of communication. They come with competencies of oh gosh, decision making. They come, and so we can put those skills maybe to use. For example, it could be having them collect the history of a patient. If you've got a history checklist, you can have your students be doing that checklist and before the patients come to see you and going through this checklist. Um, so and most of them will probably be able to do that, and then you can debrief that checklist, and through that checklist of working on that checklist they start to develop competence in gathering a patient history. So I think thinking about it more from an experiential, we often think of our competencies as high risk uh, and that that they are the they are the goal to reach. But what I'm finding is there's some students who they're learning despite us. We may not actually be teaching them anything. I don't know if I've
Yeah.
answered that very well, but
Yeah.
what I am starting to realize is that perhaps our competency profiles are not the way to go, and instead we should be identifying how much context entry-level students should be able to navigate. So, for example, what kind of cases should a student be able to navigate? So almost back to the a logbook idea, but then also add contextual cues, like should you be able to navigate a routine X-ray, of course. But now what kind of patient? An obese patient, um, uh, a paraplegic patient, and start adding some of the patient context. and maybe adding the setting as a context and figuring out what is that context that an entry-level graduate should be able to navigate to be considered competent. And I think if you think of it that way, then that's talking about more capability than competence.
Thank you. That's a good answer, I think. There isn't any more questions that have come through. One comment that I will make, though, is kind of off the back of one of the comments that has come through, and this is from Pam, who said, "Excellent presentation, worth getting up so early in the morning for it." I'm going to go the other side of it and say it was an excellent presentation, and it was worth staying up very late at night for it at the same time as well. So thank you very much, Marsha, for taking the time to put your presentation together and present that to us as well. That does wrap up our webinar for today. And what I do want to say to everyone is thank you very much for coming along. Coming up next month, we will be treated to a couple of webinars from the ISRRT. September 7th this year is a very special day for medical radiation practitioners, as it's the first World Radiotherapy Awareness Day. And the theme for this year is One Voice for Radiotherapy. And the ISRRT will be hosting a special webinar on September the 3rd with two of the founders of World Radiotherapy Awareness Day, being Dr. Katie Wakeham and Professor Michelle Leach. And they will be discussing World Radiotherapy Awareness Day, as well as addressing the global challenges for radiation therapists with one voice. I think we do have the promotional flyer that we're going to possibly put up. Thankful to you for taking that time to present to us, and that. So thank you very much.
Thank you, Steve. It was lovely to be here.
Thank you. And for everyone else, thank you very much again for attending. And it's nice to see you all again, and we will see you again shortly. Thank you.